afternoon, everyone. So I'll be talking about some myths which are there with amblyopia, which obviously with the PEDIC group large studies on ATS, those myths have been removed, and now we have lots of new treatment modalities which are coming up for amblyopia, which are actually not like conventional treatments. So as we all know, amblyopia is maybe a unilateral or a bilateral decrease in vision resulting from an abnormal visual input or an abnormal development of neurons, occurring usually till 7 to 10 years of age, but now with the concept of plasticity of the visual system, there are a lot more therapies which have come up for management of amblyopia. We all know the usual causes, the deprivation, the strabismus, and the refractive causes. But earlier, amblyopia was being considered a dogma. Only early diagnosis will help. Full-time patching was thought to be imperative. And it was thought that treatment beyond 9 years is a dead cause. But now, with the PEDIC group, which has undertaken these amblyopia treatment studies over 100 different centers, and have published these 18 studies, some of these myths I'll be talking about, which have been removed by these studies. Earlier it was thought that only patching is the gold standard of treatment, and full-time patching is imperative. But what is the fact? We all know that patching is definitely an effective treatment. Better in preschool children, has a faster recovery and a shorter duration of treatment, but remember, younger the child, the risk of occlusion amblyopia is also more, and besides the stigma of wearing a patch, besides the problem of irritation which may occur in some children with the skin allergies and all. So the major paradigm shift which has come up of the full-time patching is a part-time patching. It works as well as full-time patching. And this is what the ATS study 2A and 2B have told. For moderate amblyopes, 2 hours of patching was found to be almost equivalent to 6 hours of patching. Although the group of 6 hours of patching had a faster improvement, but the end result was the same. For severe amblyopia, at the end of treatment period, a full-time patching compared to 6 hours of patching was almost found to be equivalent. And always remember, higher the hours of patching, poor will be compliance. And compliance is a big issue, as we all know, with patching. So obviously, having 6 hours of patching for severe amblyopia works equally well, because these patients usually have a very, very poor vision. They may not be able to do their daily needs if they are given a full-time patching. Second paradigm shift is actual patch is not necessary. As I said, patching is not the only treatment we have, so we can replace it with atropine penalization. So the ATS study 1 found that atropine for penalization is as effective as patching. And although, again, the occlusion group had a faster improvement or a quicker improvement, then the second thing which the ATS said was a daily atropine versus atropine once a week, again had similar results, except that obviously the better compliance was there if you give weekly atropine, and improvement was almost equivalent. Then the second myth is amblyopia cannot be treated after a certain age, as I said, but now we know brain is neuroplastic. So it is not that we are at a dead end. So we can work beyond the critical period, which was thought to be a critical period till a particular age of 7 to 9 years, but now that limit is not there. So successful treatment of amblyopia is possible outside the critical period. It has been seen by the ATS 3 studies, different groups in that optical correction alone improves about 1/4 of the patients who are beyond 7 years of age. Prescribing 2 to 6 hours of patching with near activities and atropine further helps in improvement, especially even if they have been treated earlier with patching alone or have not been treated at all. And for patients, again, above 12 years of age, even where they have not been previously treated, just doing patching with near activities will help improve their visual acuity. So patching is effective in older children. So it is not that patching is not effective in older children. Every child, every older adolescent, and even an adult should be given a trial of patching or an amblyopia therapy, I would say. So window of opportunity is no longer limited to that period of 7 to 9 years. You can treat even in adulthood, early adulthood, and adolescent age. Second thing is treatment of amblyopia is most effective with children. Obviously, as I said, it is more effective younger the child is. So it is more effective in children who are less than 7 years of age. But children beyond 13 years of age also have shown improvement, although the response to treatment may be slower, may be requiring a higher duration or time of patching, and the extent of recovery may be less complete. It may not be totally complete, as this was found in the ATS 3 studies. Then the next myth is glasses alone may not help. So how well do glasses alone treat amblyopia? This is another myth which is there. As I said, optical correction alone will help in treating 1/3 of the patients. and help in the improvement of the visual acuity, constant use of glasses in these patients, whether it is anisometropic, whether it is strabismic or a mixed amblyopia, it works in all cases. And it is the ATS-5 and ATS-7 and ATS-13. All the studies were based on the refractive correction for different types of amblyopias. And they found even for higher refractive errors, those with anisometropic amblyops, those with strabismic amblyops, or those with mixed amblyops, all of them did have some improvement with just refractive corrections. The effect of optic curvature, although, would decrease with increasing density. So if the severity of amblyopia is more, it may not work as well as for a milder or moderate amblyopias and with the advancing age of the child. Then the next is near activities are important for patching efficacy. So do the near activities actually enhance the efficacy of patching? So it was the ATS-6 which found, yes, that patching with near work does improve visual acuity faster if it is done along with patching, if the near work is given at the time of patching, rather than people who are not doing any near work at the time when they are having the patching being done for the eye. So next myth is, once the vision stops improving, should we stop the treatment? So the next is, very, very high rates of recurrence have been seen if the amblyopia treatment is just suddenly stopped. So it is important that you should not just stop it like that once you have achieved a certain particular visual acuity or you have reached a plateau. It is important to continue for at least in my practice, I usually continue for almost 3 months after my initial thing before I stop the treatment, any form of treatment, following the resolution of amblyopia. Second is, greater recurrences have been seen with the greater, if the visual acuity at the end of treatment and a greater number of lines of improvement have been there, or if there is a previous history of recurrence. So in all these cases, you may have to customize your treatment, and customize your treatment even after achieving a good visual acuity or a visual acuity of 20 by 20 or 6 by 6 at the end of the period. So the patient is not cured once he has achieved a visual acuity of 20 by 20. It doesn't mean the amblyopic eye is seeing almost exactly like a non-amblyopic eye, fellow eye. So should we stop the therapy? No, because we know amblyopia is not a monocular disease. This is a new thing which has come, a major paradigm shift. Patching alone is not enough. We need to work on the vision therapy systems. So the neotherapies, which are, the neotherapies which have come out with the behavioral treatments, the perceptual learning, which is basically the dioptic therapy using virtual reality games or using video games, using VTS systems, and along with pharmacotherapies. Pharmacotherapies are still under trial, and the role of your high frequency transcranial randomized stimulations, which is again under trials. So the only thing which I talk about is the dioptic therapy, which has actually taken up a lead over the patching treatments, especially for mild to moderate amblyops. I have stopped using patching for mild to moderate amblyops. You can directly start with dioptic therapies in these patients, and they usually work very well for these patients. You have anaglyphic glasses, red-green glasses to be used. We have puzzle games available both for the iPads, which is a Tetris, for the Apple groups, and for the Samsung, or for the other thing, we have other games as a lazy eye groups. And then we have these virtual reality systems, which are there again based on the dioptic systems, which can be paired with the shutter glasses to enhance the effect of the patching as well as the dioptic therapy at the same time. So just to conclude, I would say that we know that early identification and intervention in the critical age group would definitely lead to better results, better recovery and restoration of not only the visual acuity, which is not just our purpose. Our purpose is to restore the binocularity of the child. But never say it's too late to any child or any parent who's coming, even at an adolescent or a person who's coming in his college days and early adulthood. Every lazy eye deserves treatment. Thank you.
Thank you, Dr. Vinita, for detailing all the thing. As she said rightly, you customize that management. That is very important. And now you should all be available about the software therapy, whatever is available in the market, and which is the one. See, there are many dealers coming that this is good, that is good, but you should be able to judge which is going to be good for that particular. You should not waste your time on checking it. So that should be selection. And one more thing, this customization also should be kept upon the age and then capability or cooperation of the patient. And the amount of visual loss. Supposing the child has got 1/60 vision in one eye or 660 vision in one eye, other eye is thing, and the child is infant or toddler, definitely that child will cooperate very nicely for our patching. Or will not cooperate, but with our thing we can make them do it. But little bit older age group, the same thing you are finding, 2-year, 3-year-old, will never comply for it. So then think about what exactly to be done. So it is not only the thing, but you should also think about the age and then the extent of the visual loss and then the available modes and the background education of the parents and the patient, and then you select your thing, definitely all of us will be successful in managing amblyopia therapy. Thank you.
Thank you, ma'am, for